you about antibiotic therapy in pneumonia. So, if your patient is an OPD patient and uncomplicated, what we will use is macrolides and tetracycline. We will use Clarithrol 500 mg BD for 7 days or Azithral 500 mg OD for 5 days. Actually, on day 1 you give 500 mg and 2 to 5 you give 200 mg, 250 mg OD. Or you can give doxycycline 100 mg BD for 14 days, which is a second line choice. Primary choice is a macrolide only. You can also give respiratory fluoroquinolones, but the CDC does not recommend it. If your patient is OPD but with significant comorbidities, you can use fluoroquinolone, beta-lactamase inhibitor plus macrolide. So if you are using fluoroquinolone, you will use levofloxacin 750 mg OD for 5 days or moxiflox 500 mg daily for 7 days. If you are not using fluoroquinolone, you can give beta-lactamase inhibitor plus macrolide like Augmentin 2 gram BD plus Azithral 500 mg OD for 5 days. So Augmentin 2 gram BD plus Azithro 500 mg OD for 5 days. Do not give fluoroquinolone to patients with myasthenia gravis. It causes myopathy and tendon rupture. If you are giving IPD treatment to non-ICU community acquired pneumonia, IPD. In IPD patients, what we will give if similar like fluoroquinolone or beta-lactamase inhibitor plus macrolide, but in IV dose. So fluoroquinolone, levofloxacin 750 mg IV or moxifloxacin 400 mg, or we can use zone plus azithro. So zone plus azithro is a very good combination if you are in ward. So yellow area you can give zone plus azithro. Other third generation cephalosporin may also be used with other macrolides or doxycycline. Doxycycline and azithromycin are used for atypical coverage. Then if we give to patient with suspected healthcare associated pneumonia, so in healthcare associated pneumonia there is a risk of Pseudomonas. We will give an anti-pseudomonal cover plus fluoroquinolone plus anti-MRSA. So in healthcare associated pneumonia we give a Pseudomonas plus MRSA cover. So anti-Pseudomonas cover can be given with cefepime or ceftazidime. What are the anti-Pseudomonal drugs? So anti-Pseudomonal drugs are piperacillin tazobactam, ciprofloxacin, monobactam like aztreonam, moxifloxacin and levofloxacin. Anti-Pseudomonal drugs can be remembered by the mnemonic campfire. So remember, Pseudomonas is camping and lighting a fire. It is carbapenem, your meropenem and imipenem, aminoglycosides like amikacin, gentamicin, tropramycin. There is monobactam like aztreonam, piperacillin tazobactam, fluoroquinolone, idime like ceftazidime drug, which is third generation cephalosporin, then cefepime and ceftolazone. So what is the crux of healthcare associated pneumonia? It is anti-Pseudomonas cover plus MRSA cover. So for anti-Pseudomonas cover you can give a third generation cephalosporin like cefepime, ceftazidime plus fluoroquinolone plus vancomycin for MRSA cover. Or you can give anti-Pseudomonal carbapenem like imipenem or meropenem plus ciprofloxacin plus MRSA cover, which is vanco. Or you could give piptaz plus ciprofloxacin plus vanco. In ICU patient, what will you use is zone plus azithro. If the patient is stable, you will use zone plus fluoroquinolone, or you can use fluoroquinolone plus aztreonam or clindamycin. You will also add anti-MRSA drug vancomycin or linezolid in patients with healthcare associated pneumonia risk. Aztreonam plus moxiflox, aztreonam plus Fluoroquinolone is used in patients who are penicillin allergic. So we can use either aztreonam plus moxi or clindamycin plus moxi. And above these regime like zone plus acethro plus zone plus moxi और एस्ट्रियोनाम प्लस मॉक्सी, क्लिंडा प्लस मॉक्सी, तो आपका जोन, क्लिंडा और एस्ट्रियोनाम का मॉक्सी के संग कॉम्बिनेशन बनेगा. मॉक्सी बेसिकली एनी फ्लोरोक्विनोलॉन, तो जोन, क्लिंडा और एस्ट्रियोनाम का एनी फ्लोरोक्विनोलॉन के संग कॉम्बिनेशन बनेगा. You can add vancomycin or linezolid to these regime if you want to also give MRSA cover. You can also remember the anti-pseudomonal antibiotics by a mnemonic. Mafia Pseudomonas challenges clinicians. Mafia is meropenem, aztreonam, fluoroquinolones, imipenem, aminoglycosides like gentamicin, tobramycin, and Pseudomonas ka P is piptase, C-cefepime and ceftazidime. It is a much more easier mnemonic. Mero, aztreonam, fluoroquinolone, imipenem, aminoglycoside, piptase, ceftazidime and cefepime. The pneumonia severity index is the best studied and recommended tool for mortality risk. And curve 65 rule looks at the presence of confusion, uremia more than 7, respiratory rate more than 30, and BP less than 90/60, age more than 65 years old. So confusion, uremia more than 7 and rate more than 30. What are the components of pneumonia severity index? They are demographic, means your gender, coexisting illness, physical examination, ancillary studies, and then there are systemic points. So demograph, coexisting illness, physical examination and ancillary studies. Demographic, coexisting illness, physical exam, ancillary studies. Demographics, coexisting illness, physical exam and ancillary studies. What is aspiration pneumonia? Aspiration pneumonia is not the same as aspiration pneumonitis. Aspiration is the inhalation of oropharyngeal content into the respiratory tract. Aspiration pneumonia is the inhalation of infectious material from the oropharynx into the respiratory tract. So, oropharyngeal bacteria or infectious material goes into the respiratory tract. While aspiration pneumonitis is actually just inflammation, it is non-infectious. Pneumonitis is non-infectious. It is an irritation and inflammation response to aspirated material, likely food particles or some chemical, but it is non-infectious. Pneumonitis develops when the aspirated material has a low pH, acidic, or when other components of aspirate cause an inflammatory or irritant response. But pneumonitis is non-infectious. Pneumonia is infectious. What are the risk factors for aspiration? These are advanced age, altered level of consciousness, anatomical abnormalities, dementia, esophageal and GI disorder, poor oral hygiene, prior history of aspiration, prolonged supine position. So we need to keep the patient in proper position. Retained gastric material and NG tube feedings. Which antibiotics will we use? We will use clindamycin, carbapenem, ampicillin sulbactam and moxifloxacin in aspiration pneumonia. Repeat again. Clindamycin, carbapenem, ampicillin sulbactam and moxiflox. CCAM. Clindamycin, carbapenem, ampicillin sulbactam and moxiflox. What are the non-infectious causes of pulmonary infiltrates? Remember ABPA, eosinophilic lung disease, hypersensitivity pneumonitis, BOOP or COOP, then ANCA-associated vasculitis, interstitial pneumonia, sarcoid, good posture, drug-induced, chemical, radiation, alveolar cell carcinoma, leukemic infiltrates, fat emboli, alveolar hemorrhage and ARDS. So this is a mnemonic for non-infectious infiltrates on a chest x-ray. Non-infectious causes of chest x-ray infiltrates. First is near drowning, then oxygen therapy, then transfusion or trauma, CNS disorder, ARDS, aspiration, altitude sickness, renal disorder, drugs, inhaled toxin, allergic alveolitis or contrast. You can also use a mnemonic AEIOU, in which alveolar sarcoid, eosinophilic pneumonia, infarction, organizing pneumonia, UIP, and contusion. What are the common causes of empyema? So it is mostly bacterial and your anaerobes, and it can be caused by Pseudomonas, MRSA, and fungus also sometimes. Tuberculosis causes empyema, and cavitary lung lesions are caused by bacteria like anaerobic abscess, infected bullae, tuberculosis, actinomyces. Fungus is coccidioidomycosis, histoplasma, blastomyces, and aspergillus. Parasitic, and we can have neoplastic like bronchogenic carcinoma, squamous cell of adenocarcinoma, metastatic cancer, and lymphoma. Inflammatory are sarcoidosis and Wegener's, and other are foreign body aspirations. So sarcoidosis and Wegener's cause cavity. What are the DDs of hematuria plus hemoptysis? They are Wegener's, good pasture, and microscopic polyangiitis. What are the reasons for medical treatment failure in lung abscess? And you need to think about it, because if you do not think about it, you are never going to diagnose it timely. First is bronchial obstruction by neoplasm or a foreign body. You can easily diagnose it with a bronchoscopy. Second is non-bacterial cause like neoplasm, fungi, vasculitis, and pulmonary sequestration.